All right. Good afternoon, everyone. As part of the ongoing partnership between the New York State chapter of the American College of Clinical Pharmacy and the New York State Council of Health Systems Pharmacists, we would like to welcome you to our annual webinar entitled Catching the Flow, Clinical Insights on the Management of UTIs for Pharmacists. And today we're thrilled to have Dr. Yumi Lee as our guest, who will be presenting. Dr. Lee is a tenured associate clinical professor at St. John's University College of Pharmacy and Health Sciences. She specializes in infectious diseases, and she has a clinical practice site at Nassau University Medical Center in East Meadow, New York. At NUMC, Dr. Lee practices as an infectious diseases pharmacy specialist and co-chairs the institution's antimicrobial stewardship committee. Dr. Lee completed her infectious diseases postgraduate training at SUNY Downstate Medical Center in Brooklyn, New York. She is board certified in infectious diseases pharmacotherapy. Dr. Lee has been a speaker at various conferences at both state and national levels and has published articles in peer-reviewed journals. Her research interests include the implementation and advancement of antimicrobial stewardship and enhancing student engagement in pharmacy education. She is involved in NYSCHP this year as the co-chair for the faculty and student committee and involved in the Society of Infectious Diseases Pharmacists in the membership committee. Before we get started, I'd like to just share a few quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office, and every effort will be made to assist in a resolution. For those who have questions that you would like to direct to the speaker, please use either the question box or chat option. And the instructions to claim CE for this session will be provided at the end of the program. And with that, I'll turn it over to Dr. Lee.
Thank you so much for that introduction, and good afternoon, everyone. Thank you for joining this presentation on managing urinary tract infections, or UTIs. This topic is definitely one that I think all of us encounter almost daily in our practice, whether it be through patient consultations, dispensing antibiotics, or navigating the complexities of treatment recommendations. So whether you are new to this topic or well-versed in it, I hope to share some insights that are practical and relevant to your practice. I do not have any financial relationships to disclose. And for today's objectives, we'll start by reviewing the latest UTI guidelines and discussing some clinical challenges given the current state of antimicrobial resistance. And this is followed by an in-depth look at the evidence-based approaches in treating UTIs caused by resistant organisms. And lastly, we will talk about how pharmacists can play a critical role in improving patient outcomes and optimizing antimicrobial use in patients with UTIs, focusing on some antimicrobial stewardship strategies. Reviewing UTIs just in a broader context to start with, about 50 to 60% of women have at least one UTIs in their lifetime. In the hospital setting, UTIs are the most common type of healthcare-associated infections that is reported to the National Healthcare Safety Network. This is the CDC's system for tracking healthcare-associated infections. When looking specifically at CAUTIs, which are catheter-associated urinary tract infections, there is about a 3 to 7% increased risk of acquiring a UTI per each catheter day, and stats show that approximately 12 to 16% of adults will have an indwelling catheter. And it is estimated that UTIs are associated with more than 13,000 deaths each year and accounts for one of the most common reasons for antibiotic prescribing. UTIs aren't a one-size-fits-all condition. There are distinct types, and each with a very specific implication for its treatment and management. So this understanding is really important for providing patient-centered care and making informed treatment decisions. The distinctions are usually categorized as an acute, uncomplicated UTI, which we also refer to as like a simple cystitis. And this is an infection that is confined to the bladder. People with cystitis are typically immunocompetent. They have a normal urinary tract anatomy, and they typically complain of symptoms such as dysuria, which is pain upon urination, urinary frequency, urinary urgency, or suprapubic pain in the absence of any systemic illness. So complicated UTIs are pyelonephritis, which are infections that is extending beyond the bladder, prostatitis, and as well as catheter-associated UTIs. Patients with complicated UTIs can experience all the symptoms of a patient with a simple cystitis, but they usually present with systemic illness as well. So these are going to be the patients that present with fever, chills, rigors, fatigue or malaise, flank pain, costovertebral angle tenderness, and pelvic pain or perineal pain in men. So pregnant patients and renal transplant recipients are considered special populations. We won't really be discussing these types of patients in today's presentation, but typically they have a lower threshold for initiating and starting antibiotics. When talking about the diagnosis of a UTI, so that's usually made primarily by the presence of symptoms and can be confirmed by two main laboratory tests. These two tests should be performed on a urine that is collected from a midstream void. The two lab tests are a urinalysis and a urine culture. So in a urinalysis, where we often call in clinical practice like a UA, it includes a urine microscopy and a urinary dipstick. The urine microscopy helps us identify the presence of WBCs in the urine, which we call pyuria. And having 10 or more WBCs per microliter of urine is suggestive of a UTI. The presence of WBCs in the urine actually has a pretty high negative predictive value. So that means that without pyuria, it is unlikely that a patient actually has a UTI. So when looking at a urine dipstick, the two things that we kind of focus on are the leukocyte esterases and nitrites. Leukocyte esterase is an enzyme that is released when WBCs are lysed, so it kind of acts as a surrogate marker for pyuria. Nitrites in the urine are attributed to the ability of some gram-negative bacteria like E. coli to convert urine nitrate to nitrite. So a positive nitrate on a urine dipstick can be an indicator for the presence of bacteria in the urine, which we call bacteriuria. But we have to be mindful, I think, about other organisms such as Pseudomonas that can also cause UTIs, but Pseudomonas does not have the ability to convert to nitrite. So a negative nitrite test cannot be used to rule out bacteriuria or a UTI. Performing a urine culture will help us identify the pathogen as well as the presence of bacteria. So the classic cutoff for a positive urine culture to reflect the presence of bacteriuria is more than 10 to the 5th colony forming units per ml. So in the setting of uncomplicated cystitis, having these classic symptoms of a UTI can be sufficient sometimes to make a clinical diagnosis without the laboratory testing. But with the diagnosis of pyelonephritis, it should be made by like a full clinical assessment as well as a laboratory testing like a urinalysis and a urine culture. And sometimes for even more complicated patients, they may need imaging. So the usual mechanism of a urinary tract infection is bacteria that colonizes the urethra or the periurethral space, and then it migrates into the bladder. The bacteria that is typically causing UTIs are usually from the GI tract, and they are collectively called the Enterobacterales. So examples of Enterobacterales includes E. coli, Klebsiella pneumoniae, and Proteus mirabilis. E. coli is the most frequent cause of UTIs, and then other uropathogens include Pseudomonas, Enterococci, as well as Staphylococci, including both MRSA and MSSA. So the prevalence of particular pathogens really depends on the host. So as an example, Pseudomonas is more common in patients with healthcare exposures or those that undergoes like instrumentation, while Staphylococcus saprophyticus is an occasional cause of pyelonephritis in young and otherwise healthy women in the community. Increasing rates of resistance have been reported globally. In order for us to optimize empiric antibiotics, we have to have ongoing monitoring of resistance. So the in vitro susceptibility of E. coli varies considerably based on the geographic region. The US has a higher rate of resistant E. coli when compared to Canada, and Portugal and Spain have higher rates of resistance when compared to other European countries. So it's kind of to further illustrate the rise in resistance in the United States. There was a study that reported a threefold increase in the prevalence of ESBL producing Enterobacterialis amongst hospitalized patients with UTIs from 2000 to 2009. And in another study of just E. coli urinary isolates from outpatients in the United States, the resistant rates to ciprofloxacin increased from 3 to 17% between 2000 and 2010. So let's take a moment here to kind of further explore antimicrobial resistance and how it affects UTIs a little more closely. In this study that was published in the Lancet, they performed a systematic analysis to look at the burden of bacterial antimicrobial resistance in 2009. So for UTIs in particular, it was ranked number 4 in global deaths attributable to and associated with bacterial antimicrobial resistance. And this follows after lower respiratory tract infections, bloodstream infections, and intra-abdominal infections. And this graph here is from a study that aimed to provide comprehensive global and regional estimates for the antimicrobial resistance burden of UTIs, also done in 2019. The graph here depicts that the number of attributable or associated deaths with antimicrobial resistance in UTIs amongst 21 global burden disease regions. And you may appreciate that in high-income North America, it ranks number 6. And surprisingly, or actually I should say unsurprisingly, in the same study, E. coli is the organism responsible for the most antimicrobial resistant UTI associated deaths. And this different systematic review and meta-analysis published in 2021, it looked at the virulence factors and antimicrobial resistance of E. coli isolates from urinary tract infections. It included 8 different countries with both inpatients and outpatients. And if we take a look at the top portion of this graph, high frequency of antimicrobial resistance were found to numerous antibiotic classes. 70% were resistant to tetracyclines, 60% to sulfonamides, 50% to the fluoroquinolones, and 40% to beta-lactams. And then amongst the beta-lactams, as shown in the bottom portion here, the highest rates of resistance were to aminopenicillins. So these are your amoxicillin and ampicillins. So I just want to take a brief moment here to recap urinary tract infections, right? So far what we know is that UTIs are one of the most common infections that we see in clinical practice, and it accounts for one of the most common indications for antibiotic prescribing. So when there are a lot of antibiotics being used, it means there's a lot of work for antibiotic stewardship. Diagnosing a UTI can be challenging. Sometimes it can be difficult to differentiate between a true infection and an asymptomatic bacteriuria, especially in elderly. Misdiagnosing a UTI can lead to unnecessary antibiotic use, right? And then the most common urinary pathogen that we see is E. coli, and what we're seeing is resistance. So this resistance really complicates our treatment decisions. So in light of all of these challenges, really staying informed about the latest guidelines and the resistant trends is really crucial for managing UTIs effectively and responsibly. However, this is a screenshot of what we see when we go on the Infectious Disease Society of America's website for the latest UTI guidelines. They were last updated in 2010, and now they are archived. So a new set of guidelines are in development, and what's frustrating is that it is taking this development a really long time to come out. So I was just at the ID Week conference a few weeks ago, and I actually did not hear any updates as to when the new guidelines would be coming out. So this is what we've got for now. Okay, so looking at the 2010 guidelines, when treating uncomplicated cystitis, which can be treated as an outpatient, Nitrofurantoin at 100 milligrams twice a day for 5 days is recommended due to minimal resistance and propensity for collateral damage. Its efficacy has also been shown comparable to 3 days of trimsulfa. Trimsulfa with the 1 double-strength tablet twice a day for 3 days is another option, given its efficacy that was shown in a lot of clinical trials. So the threshold of resistance that has been established for trimsulfa is 20%. So this means that if resistance is 20% or greater, this drug is no longer recommended for empiric treatment of acute cystitis. And lastly, fosfomycin 3 grams as a single dose is another option. It also does have minimal resistance and propensity for collateral damage, but the challenge for fosfomycin is that it is not uniformly available and that susceptibilities for this drug is not typically done in microlabs. Continuing with uncomplicated UTIs, a 3-day course of Cipro or levofloxacin is in the 2010 guidelines. We know fluoroquinolones are highly effective in the treatment of UTIs, but they do have a propensity for collateral damage, and alternative agents should be considered. Oral beta-lactams such as amoxicillin clavulanate, cefdinir, cefaclor, cefodoxime, and cephalexin can be options when other recommended agents cannot be used. As we kind of said before, ampicillin or amoxicillin should never be used for empiric treatment given the high prevalence of resistance to these agents. In general, beta-lactams are considered second-line agents because they are less effective and have more potential adverse effects than other UTI antibiotics. However, I do want to note here that there are some data out there that suggests oral beta-lactams are safe and effective in UTIs, and this is especially in like step-down therapy. I do want to take a quick moment here to talk about collateral damage. Collateral damage is a term that is used to describe the adverse ecological effects of antibiotic therapy. So we're talking about the selection of drug-resistant organisms, and we're talking about the adverse events associated with antibiotics such as C. diff, right, with damage to the gut flora. Specifically with fluoroquinolones, they are associated with many FDA safety warnings such as tendon rupture, hypoglycemia, neuropsychiatric effects, peripheral neuropathy, and QT prolongation. So this mixed fluoroquinolones are really unattractive option, and so much that the FDA has actually put out a statement advising that the serious side effects associated with fluoroquinolones outweighs the benefits in patients with acute sinusitis, acute bronchitis, and uncomplicated urinary tract infections. So because of these reasons, we really don't want to use fluoroquinolones as first lines, especially when there are safer alternatives available. So looking at acute pyelonephritis or complicated UTIs that does not require hospitalizations, the 2010 guidelines recommend using quinolones, either ciprofloxacin or levofloxacin, but if the local resistance rates to quinolones are greater than 10%, then an initial dose of ceftriaxone or aminoglycosides should be given. Trimsulfa for 14 days is also recommended, but if there is local resistance or unknown resistance, then an initial dose of ceftriaxone or aminoglycosides should also be given. And then oral beta-lactams are also in the 2010 guidelines, again, and traditionally they are looked at as a less effective agent compared to the other UTI agents. So if used, an initial dose of ceftriaxone or aminoglycosides should be given again in those patients with acute pyelonephritis. Now with acute pyelonephritis that requires hospitalization, right? The decision to admit patients with acute complicated UTIs is usually straightforward when the patients are septic or otherwise critically ill. In other cases, typical reasons for inpatient management include persistently high fevers, severe pain, marked debility, or inability to maintain oral hydration, or they cannot tolerate oral medications. For pyelonephritis requiring hospitalizations, the 2010 guidelines recommend treatment with fluoroquinolone, aminoglycosides with or without ampicillin, and extended spectrum cephalosporin with and without aminoglycoside, or a carbapenem. The choice among these agents should be guided by local resistance data and susceptibility data. So just to recap the recommendations from the 2010 UTI guidelines, right? So for uncomplicated UTIs, the preferred oral treatment options are nitrofurantoin, trimsulfa, or fosfomycin. For complicated UTIs that do not require hospitalizations, fluoroquinolones can be used if resistant rates are below 10%, and other options include trimsulfa and oral beta-lactams as your alternatives. For complicated UTIs requiring hospitalizations, recommended treatments include a fluoroquinolone, an aminoglycoside with or without an ampicillin, an extended spectrum cephalosporin with or without an aminoglycoside, or a carbapenem. So what are we really getting at, right? What we're really seeing is that all of these recommendations is really based on local resistance data. So if fluoroquinolone resistance is greater than 10%, then we cannot use it. If trimsulfa resistance is greater than 20%, then we cannot use it. And that goes the same for any antibiotic that we are considering. So the bottom line is that we need to know our local resistance data and susceptibility data in order to help us guide therapy. So what are we dealing with really? How bad is the resistance out there? Here on the slide, what we are seeing is the CDC data on the antimicrobial resistance burden of the 7 resistant pathogens found in the healthcare settings in the US. So if we just focus on the gram-negative bacteria, there has been increasing rates of hospital onset carbapenem-resistant Enterobacterales, Acinetobacter, ESBL-producing Enterobacterales, as well as multi-drug resistant Pseudomonas when we compare these numbers from 2022 to 2019. So the CDC noted that this increase could be reflective of the impact of COVID-19, which really pushed healthcare facilities near their breaking points, right? So during the pandemic, patients were staying in the hospital for much longer, so they had longer hospital stays. Infection prevention and control practices were really not optimal, and that there was an increase in inappropriate antibiotic use at that time. So to further explore just how bad resistance is, we can take a look at these 2 really useful platforms. One of them is the Antimicrobial Resistance and Patient Safety Portal. It's actually a pretty cool interactive website that was created to display all of the data that was collected through the CDC's National Healthcare Safety Network and the Antimicrobial Resistant Laboratory Network. So they got all of this data together to provide data in this really interactive format on a state level. And then the other useful platform is the First Line app, which is a mobile application that's supported by the New York City Department of Health and Mental Hygiene. They developed this regional antibiogram that encompasses all 5 boroughs of New York City. So in the next couple of slides, what I want to do is go through some of these data from these 2 useful platforms, and then we can explore the landscape of resistance that's specific to New York State compared to the rest of the US. So here is a page right off of the CDC's antimicrobial resistance and patient safety portal, and it looks at MDR, which is multi-drug resistant E. coli in New York State. So on the website, you're actually able to filter it by the type of healthcare-associated infection that you want to look at and the region, and in which on this slide here, I have filtered this map out to CAUTIs, right, catheter-associated UTI infections, and New York State. So in 2021, New York State reported an 8% resistant rates in multi-drug resistant E. coli. And then now specifically looking at E. coli and the fluoroquinolone resistance. So as per the CDC, the resistant rates for fluoroquinolones in UTIs found in CAUTIs was 34.2%. Looking at the New York City-wide antibiogram in the First Line app, for all E. coli isolates in 2020 and 2021, ciprofloxacin was 32% resistant and trimsulfa was 24% resistant. So remember, both of these agents are recommended in the 2010 UIDSA UTI guidelines, but contingent on resistant rates. So to put this into perspective, right? If you're in New York City or treating a patient in New York City, given a patient trim sulfa for UTI could mean that they would have potentially a 24% chance of failure. Okay, so going back to some of the CDC data, in CAUTIs specifically, carbapenem-resistant Enterobacterales was 4%, and in New York, and then this is compared to 2.6% in the United States in 2021. Breaking down the different Enterobacterales species, 0.9% of E. coli were carbapenem-resistant, 9% of Klebsiella were carbapenem-resistant, and 10% of Enterobacter species were carbapenem-resistant. And then now looking at Pseudomonas aeruginosa in New York State, the carbapenem-resistant rates was about 25% compared to 16% in the US. So how did we get here, right? How do the bugs do it? Really, gram-negative bacteria can each have their unique way of producing antibiotic resistance. Antibiotic resistance can be intrinsic or they can be acquired, and typically the antibiotic stops working because of one or more of these reasons. If the antibiotic cannot get to the target site, that is usually due to a loss of porin channels or an increase in efflux pumps. If the antibiotic gets modified, this is usually due to enzyme hydrolysis or modification. And when the antibiotic cannot get to the target site, this can be due to a modification, production, or bypassing the target site. So the topic of antibiotic resistance is very complex, especially when it comes to gram-negative bacteria that are capable of producing multiple mechanisms of resistance at once. So in other words, gram-negative resistance can occur by having multiple of these mechanisms, right? So this is an awesome slide that was created by a fellow ID pharmacist, Sam Aiken from Michigan. I really like this graphic because I think it really helps us visualize the different mechanism of resistance. So when we talk about efflux pumps, these pumps reduce the antibiotic capacity to remain in the bacterial cell by pumping it back out. And then this typically affects the beta-lactams, aminoglycosides, tetracyclines, and the quinolones. So with the loss of porin channels, mainly affecting beta-lactams, this reduces the antibiotic capacity to enter the bacterial cell. Target bypass is a mechanism of resistance that involves the production of new proteins or targets that are not susceptible to the antibiotics. And enzymatic drug modification is when the organism can produce certain enzymes that can hydrolyze the antibiotic, rendering it ineffective. So what we are seeing here is that the production of these beta-lactamases accounts for the most common mechanism of resistance to beta-lactam antibiotics amongst gram-negative bacteria. So focusing just more closely on the enzymatic resistance for the Enterobacterales, the most widely used classification of beta-lactamases is the EMBLA classification that divides these beta-lactamases into 4 different classes, A, B, C, and D. And this is all done based on their amino acid sequences. Class A beta-lactamases are the penicillinases, ESBLs, and KPCs, which stands for Klebsiella pneumoniae carbapenemases. So just note here that KPCs, although it's in the name, can be produced by other organisms besides Klebsiella pneumoniae. Class B are your carbapenemases, like your VIMs, IMs, and NDMs, also known as the metallobeta-lactamases. And they require a bivalent metal ion, usually it's zinc, for activity. Class Cs are your AMC beta-lactamases. Sometimes they are referred to as the cephalosporinases. AMCs can be inducible, non-inducible, and plasma-mediated. And Class Ds are your oxacarbapenemases. So in the world of infectious disease research and clinical practice, really figuring out how to identify and manage bacteria with ESBLs, AMCs, CREs, and KPCs present, a big clinical challenge. But thankfully, we have these IDSA guidelines. So these are the 2024 guidance on the treatment of antimicrobial resistant gram-negative infections put together by Dr. Pranita Tama and colleagues. So this set of guidance document is currently on its 4th edition, and it focuses on infections caused by ESBL enterobacterales, AMC producing enterobacterales, carbapenem-resistant enterobacterales, Pseudomonas with difficult to treat resistance, as well as carbapenem-resistant Acinetobacter and Stenotrophus monophilia. So in the next couple of slides, what I want to do is we're going to dive deeper into this document to help us understand and get to know the different treatment options for UTIs that are caused by ESBL enterobacterales, MC enterobacterales, these CREs, right, the carbapenem-resistant enterobacterales, as well as Pseudomonas aeruginosa with difficult to treat resistance. So first, let's talk about ESBLs. So ESBLs are enzymes that inactivate most penicillins, cephalosporins, and Astreonam. ESBL enterobacterales generally remain susceptible to carbapenems, and they do not inactivate non-beta-lactam agents such as ciprofloxacin, trimsulfa, and gentamicin. However, organisms carrying these ESBL genes can often harbor additional genes or mutations, which expands their resistance to a broad range of antibiotics. So any gram-negative organism has the potential to harbor this ESBL gene. However, they are most prevalent in E. coli, Klebsiella pneumoniae, Klebsiella oxytoca, and Proteus mirabilis. The CDXM enzymes are the most common ESBLs that's seen in the United States. Routine ESBL testing may not be performed by, most clinical microbiology labs, but in practice, what we do is we can use the non-susceptibility to ceftriaxone as a proxy for ESBL production. So the 2024 guidance recommends nitrofurantoin and trimsulfa as the preferred treatment options for uncomplicated UTIs caused by ESBL enterobacterales. Although carbapenems and fluoroquinolones are effective agents, their use for uncomplicated cystitis is discouraged when other effective options are available. So this recommendation is similar to the 2010 IDSA UTI guidelines. This guidance document also stresses limiting the use of carbapenems and quinolones to preserve its activity for future infections when treatment options may be more restricted. Particularly with the fluoroquinolones, limiting its use also reduces the risk of many associated toxicities and collateral damage that we discussed. Aminoglycosides is an alternative treatment option as well as oral phosphomycins. Note here that phosphomycin again should be limited to the treatment of uncomplicated ESBL enterobacterales cystitis caused by E. coli. And although phosphomycin susceptibilities are not routinely tested by most microbiology lab, in the United States, E. coli resistance to phosphomycin remains rare. And then when we're looking at the preferred treatment options for patients with ESBL enterobacterales pyelonephritis or complicated UTIs, trimsulfa, ciprofloxacin, and levofloxacin are recommended, and this is assuming that in vitro susceptibility has already been established. When resistance or toxicities prevents the use of trimsulfa or the fluoroquinolones, or if a patient is critically ill, then the carbapenems are preferred. The guidance document emphasizes that if a carbapenem is initiated, and susceptibility to trimsulfa, ciprofloxacin, or levofloxacin is shown, then transitioning to oral formulations of these agents is preferred over completing a treatment course with the carbapenem. Aminoglycosides are alternative options for pyelonephritis. Although expected to be effective, they are considered alternative agents because of the nephrotoxicity risk that's associated with it. So next we'll talk about the AMCs. So AMC beta-lactamases are capable of hydrolyzing a number of beta-lactam antibiotics. When we talk about AMCs, we can classify them into 3 different categories. We have inducible resistance, non-inducible chromosomal resistance, which is due to mutations, and you have plasma-mediated resistance. So in cases of inducible AMC expression, exposure to certain antibiotics can trigger an increased production of the AMC enzymes and the development of de-repressed mutants. So this means that an Enterobacterales strain that initially shows that it is susceptible to the antibiotics like ceftriaxone or ceftazidime will become resistant while they are on these drugs. So Enterobacter cloacae complex, Klebsiella aerogenes, and Citrobacter farundii are the most common Enterobacterales species at moderate risk for clinically significant inducible AMC production. So just to go into this and explain this maybe in a little bit simpler terms, antibiotics really differ in terms of how they trigger AMC production and also how easily they are broken down by AMCs. So on this table or list that I have on the right on this slide, I've listed the antibiotics that are strong inducers and good substrates of AMC. So like your aminopenicillins and first-generation cephalosporins. Right, so most AMC resistant strains will typically show resistance to these antibiotics. So now ceftriaxone, ceftazidime, aztreonam, and piperacillin-tazobactam, they are weak inducers of AMCs, but they are good substrates of AMCs. So this means that they are easily broken down by it. So this makes them less effective treatment options when we're dealing with organisms that are at moderate risk for clinically significant AMC production. And then we have cefepime and meropenem. They have the advantage of being both a weak inducer and poor substrate of AMC beta-lactamases. And then therefore, cefepime is generally effective and considered an effective treatment for AMC Enterobacterales UTIs. So as per the IDSA guidance, right, in the setting of both uncomplicated and complicated UTIs caused by MC Enterobacterales, the guidance recommends using nitrofurantoin and trimsulfa or fluoroquinolones. If other mechanisms of resistance are present, rendering these agents resistant, then cefepime is suggested. Okay, when talking about carbapenem-resistant Enterobacterales or CREs, these are bacteria that are resistant to at least one carbapenem antibiotic or produce a carbapenemase enzyme. So as shown on this slide that I borrowed from clinicaloptions.com, some CRE strains that are not producing carbapenemases may be resistant due to the presence of non-carbapenemase beta-lactamase genes, such as the ESBLs. So this can also go along with disruptions in the outer membrane, like saporin channels or the actions of efflux pumps. So in fact, carbapenemase producing CRE isolates accounts for up to 83% of all CRE cases in the United States. The most common carbapenemase found here are the KPCs, which again are not limited to Klebsiella pneumoniae isolates. And then other notable carbapenemases include the New Delhi metallobeta-lactamases or NDMs, as well as the VIMs, IMs, and oxycyllinases like the OX48. So NDMs, VIMs, and IMs are collectively known as the metallobeta-lactamases again. And then really understanding the specific carbapenemase that is produced by the CRE is really helpful in guiding treatment decisions, right? As we have the novel beta-lactam, beta-lactamase inhibitors, we'll get to each of those on how they target the specific carbapenemases. So what are preferred antibiotics for the treatment of uncomplicated cystitis caused by CREs? So the guidelines recommend nitrofurantoin, trimsulfa, ciprofloxacin, or levofloxacin, but they recognize that the likelihood of susceptibility to any of these agents is low. And aminoglycosides as a single dose or fosfomycin, if we're talking about E. coli, colistin, ceftazidime-avibactam, meropenem-vapobactam, imipenem-relebactam, or cefiderocol are the alternative treatment options for uncomplicated cystitis caused by CREs. And then when we're looking at the preferred antibiotics for the treatment of pyelonephritis or complicated UTIs caused by CREs, again, we have trimsulfa, ciprofloxacin, or levofloxacin that's preferred if there is susceptibility that's demonstrated. Otherwise, again, using the novel beta-lactam, beta-lactamase inhibitors such as ceftazidime-avibactam, again with the meropenem-vapobactam, imipenem-relebactam, and cefiderocols are preferred. And aminoglycosides can also be considered as an alternative. So just talking a little bit about the metallo-beta-lactamases. So these enzymes are tricky because they hydrolyze penicillins, cephalosporins, and carbapenems, but they do not hydrolyze aztreonam. So the novel beta-lactamase inhibitors do not inhibit these enzymes. And in the 2024 IDSA guidance, they recommend a combination of using ceftazidime-avibactam in combination with aztreonam, as it's shown that there has been some synergistic effects against the metallo-beta-lactamases such as VIMs and NDMs. So this combination, just to know that is not active against metallo-beta-lactamase producing Pseudomonas isolates, so only for the Enterobacterales. Cefiderocol can also be used as a monotherapy option for metallo-beta-lactamases. However, note that susceptibilities really should be confirmed because resistance with metallo-beta-lactamase producing Enterobacterales has been reported with and without prior exposure to cefiderocol. Multi-drug resistant Pseudomonas refers to strains that are resistant to at least one antibiotic from 3 or more common classes. So this includes like penicillin, cephalosporins, fluoroquinolones, aminoglycosides, and carbapenems. Pseudomonas with difficult to treat resistance is resistant to all of the following antibiotics. So they're resistant to piperacillin tazobactam, ceftazidime, cefepime, aztreonam, meropenem, imipenem, as well as the fluoroquinolones. When examining Pseudomonas isolates with difficult to treat resistance, multiple mechanisms are often at play again. So these enzymes may exhibit a combination of resistant factors, including decreased expression of porins, increased production of AMC enzymes, upregulation of efflux pumps, mutations in the penicillin binding protein targets, as well as the presence of ESBLs. So carbapenemase production is a relatively rare cause of carbapenem resistant in Pseudomonas isolates in the United States. It is more common in Latin America and Asia. So for the treatment of UTIs caused by Pseudomonas with difficult to treat resistance, the IDSA guidance recommends using ceftolozane tazobactam, ceftazidime-avibactam, imipenem-relebactam, and cefiderocol. And these recommendations are based on clinical trials, which shows non-inferiority of these agents to common comparators for the treatment of complicated UTIs. And when we're trying to compare which agent is better than the other, there is insufficient data to favor one of these agents over the other. And tobramycin or amikacin as a single dose may be considered as alternatives. So I know we just went through like a lot of information, and I think some of you may be asking like, okay, so what do we do again with multi-drug resistant UTIs that is resistant to the usual stuff? So hopefully this table here is helpful with visualizing the novel beta-lactam, beta-lactamase inhibitors and the newer beta-lactams that's come out and their in vitro activity against the different beta-lactamases. So for example, all of the agents cover ESBL Enterobacterales. Ceftolozane tazobactam also has in vitro activity against Pseudomonas isolates with difficult to treat resistance. If we are trying to cover AMC Enterobacterales, then ceftolozane tazobactam would not be a good choice, but ceftazidime-avibactam, meropenem-vapobactam, imipenem-relebactam, and cefiderocol could be alternatives, options to consider. And this goes the same for when we're dealing with carbapenem-resistant Enterobacterales. Metallo-beta-lactamases are the trickiest to deal with. Cefiderocol is considered stable against metallo-beta-lactamases. However, there has been reports of cefiderocol resistance that emerges while the patient is on therapy. And as a reminder, as per the 2024 IDSA guidance, ceftazidime, avibactam plus aztreonam is also recommended for synergistic effects. And then when we are treating Pseudomonas aeruginosa with difficult to treat resistance, all of the novel agents could be options except for meropenem-vaborbactam, because vaborbactam as the beta-lactamase inhibitor only marginally restores meropenem's activity against difficult to treat resistance, particularly with Pseudomonas. And then here on this slide, I'm bringing back up the image of the different mechanisms of resistance again. But what I've done here is added in the novel agents where they are recommended based on the resistance mechanisms. So for Pseudomonas resistance due to efflux pumps and porin loss, ceftolozane, tazobactam, and cefiderocol have in vitro activity. For carbapenem-resistant Enterobacterialis, or difficult to treat Pseudomonas due to enzymatic drug modifications like AMP-C production, the novel agents with the beta-lactamase inhibitor avibactam, vaborbactam, and relebactam could be options. So I just wanted to revisit this image again to really emphasize the importance of understanding the specific pathogen and resistance and mechanisms in order to really choose the most effective antibiotics for our patients. So now let's turn our focus to antimicrobial stewardship in UTI, which is the final portion of today's presentation. I think given how much we've discussed resistance, it is clear that antibiotic stewardship is crucial to improving patient outcomes. So this table here is from a review article by Goebel and colleagues. It provides an in-depth look at stewardship strategies for UTIs. So the authors highlight the 5 Ds of stewardship, which stands for the right diagnosis, right drug, right dose, right duration, and de-escalation. So I find this framework particularly useful for understanding the unique challenges and opportunities in UTI stewardship. So starting with the right diagnosis is key, though it is not always straightforward, right? So antibiotics are necessary if the patient is symptomatic. However, many patients are incorrectly treated for asymptomatic bacteriuria. So successful stewardship interventions to address diagnostic challenges include clinical decision support systems, improving processes for proper urine culture collections, reflex urine cultures, creating order sets, and selective reporting of urine culture results, as well as providing interpretive information with those results. So once the right diagnosis is made, it is crucial to prescribe the right drug. So in today's climate of increasing antibiotic resistance, I can't stress enough how knowing local susceptibilities through antibiograms is vital. Strategies such as selective and cascade reporting of antibiotic susceptibilities can help reduce the use of broad-spectrum antibiotics. Additional interventions like provider education, computer decision support, and pharmacist reviews also help to improve the accuracy of both empiric and definitive antibiotic choices for UTIs. And then next, with the right dosing and right duration, which are also critical elements of antibiotic stewardship. So dosing errors are common, and there is still a tendency in some people to believe that longer courses of antibiotics are always better. So to address this, strategies like computer decision support systems, order sets, doing prospective audits and feedback have proven effective in ensuring appropriate dosing and duration of antibiotics in UTIs. And then finally, we have de-escalation. De-escalation of antibiotics really plays a key role in inpatient stewardship. After obtaining culture results and susceptibility testing, antibiotics really should be narrowed down or discontinued based on the patient's clinical response. So one way to improve de-escalation is through post-prescription reviews of cultures. And to provide more insight into diagnostic stewardship for UTIs, I'd just like to highlight a study by Clays and colleagues. They developed a set of best practices for urine culture diagnostic stewardship, and they did so by surveying 15 experts. So while we often think of antibiotic stewardship with interventions that pharmacists can make with the specific, antibiotics and medications, it is equally important to really understand and emphasize on how we can contribute to accurate diagnosis as well. So diagnostic stewardship works hand in hand with other stewardship efforts, and recognizing the synergy is key. This article offers several examples, but the table that I provided here on this slide outlines the best practices for ordering urine cultures. So this includes requiring documentation of UTI signs and symptoms before ordering a urine culture, meaning that the prescribers have to put in what the signs and symptoms are of the patient that's indicative of a UTI before you can even order a urine culture. Replacing standalone urine culture orders with conditional reflex cultures is another strategy. Implementing best practice alerts to prevent cultures from being ordered without symptoms, and then automatically canceling repeat cultures within 5 days of a positive result during the same hospital admission is also another strategy. Practices to avoid include urine cultures in standard order sets and ordering cultures based solely on changes in urine appearances. So a pharmacist can play a critical role, and we can do so by reviewing a lot of these order sets, and I'm sure all of us have in the hospitals a lot, and then seeing, if there are urine cultures in this order set, is it really necessary? Can we remove it? And then we can work collaboratively with the physicians and other clinicians to help strengthen diagnostic stewardship efforts. And then recognizing risk factors for multi-drug resistant infections is essential for selecting the right empiric antibiotics, right? I always say we have to know our patient. So if a patient has any of the following risk factors within the past 3 months, it would be reasonable to suspect a multi-drug resistant UTIs. So these factors include a history of a multi-drug resistant gram-negative isolate or a quinolone resistant Pseudomonas, recent inpatient stays at healthcare facilities, use of fluoroquinolones, Bactrim or broad-spectrum beta-lactam, as well as recent travels to regions with high resistant rates, so such as India, Israel, Spain, and Mexico. And in addition to understanding the current landscape of resistance, it is also crucial to stay updated on the latest developments. So I use this here as an example. The Clinical Laboratory Standards Institute updated the MIC breakpoints for aminoglycosides in June of 2023. So for a long time, we were using aminoglycosides for double coverage against gram-negative infections in critically ill patients. However, this recent CLSI updates tells us that when treating Enterobacterales, not all aminoglycosides may be as effective due to lowered MIC breakpoints, right? So when treating Pseudomonas infections, gentamicin is no longer recommended. And amikacin is only effective for urinary tract infections, not infections outside of the urine. Tobramycin is still effective in vitro, but with a lowered breakpoint for both Enterobacterales and Pseudomonas. So this really, again, highlights the importance of staying current on these updates. And this is also that we can make sure we are giving our patients the most effective treatment choices as resistant patterns are changing and evolving. And then to conclude the presentation, I just wanted to share 2 more examples of stewardship strategies for UTIs with outcomes data. So this here is the INSPIRED randomized clinical trial. The goal was to assess whether prompts in the CPOE system, so they provided patient and pathogen-specific multi-drug resistant organism risk estimates, if having these prompts could reduce the use of empiric extended spectrum beta antibiotics for UTIs. So these prompts were part of a stewardship bundle that also included education, feedback, and real-time alerts. This was a clustered randomized trial that conducted across 59 US community hospitals, with 29 hospitals receiving this intervention. So the results were able to show that compared to routine stewardship practices, The group that used the CPOE prompts had a 17.4% reduction in the number of empiric extended spectrum antibiotics days of therapy. And in this example, the intervention took place in the emergency department. They implemented a stewardship bundle for UTIs, which disseminated institutional guidelines. They delivered brief lectures. They incorporated order sets and provided weekly audits with personalized feedback. So this study included 3 study periods: the pre-intervention, post-intervention, and the late follow-up, which took place 11 months after an 11-month phase, and it involved monthly text messages, reminders about the treatment protocol. So during the intervention period, adherence to the protocol for antibiotic selection and duration increased from 41% to 84%. And this high level of adherence was maintained in the late follow-up period at about 73%. The use of fluoroquinolones dropped to 5% during the intervention period compared to 19%, and then this remained at a 7.4% in the late follow-up period. So this antibiotic stewardship intervention in the busy emergency department really showed us that it led to improved adherence to treatment protocols, including a significant reduction in fluoroquinolone use. So these monthly reminders that they were doing in the post-follow-up period was able to sustain most of the positive effects for up to a year. So to wrap this presentation up, I want to leave you with a few key takeaways, right? So first, it is essential to understand the pathogens we are encountering in our institutions. What resistant patterns are we seeing? So make sure to review your institution's antibiograms regularly. Second, review, we need to be familiar with the available antibiotics, when to use them, and how to preserve their effectiveness. So we want to stay current with updates on new antibiotics and annual changes in MIC breakpoints. Third, we want to recognize the risk factors, right? Recognizing risk factors for resistance in our patients will help us ensure we choose the right empiric therapy. And then finally, as pharmacists, we have a significant role in UTI stewardship, whether it is with creating order sets, reviewing order sets, providing prospective audits and feedback, or participating with diagnostic stewardship. These are all different ways that we can get involved. So thank you for your attention, and I hope you take these insights back to your practice to improve patient care. I do just want to briefly mention that just 3 days ago, JAMA published an updated consensus statement and clinical guidelines for the prevention, diagnosis, and management of UTIs by the Wiki Guidelines Group. So I haven't had the chance to review this document in detail yet, and it was only published like 3 days ago. I did notice that they included a whole section on diagnostic stewardship. And then for uncomplicated cystitis, nitrofurantoin remains a reasonable first choice. For patients with pyelonephritis, trimsulfa or first-generation cephalosporin is recommended, depending on local resistant patterns. For patients requiring IV therapy, ceftriaxone was recommended. And then these guidelines also emphasize that fluoroquinolones should be avoided when possible due to their individual risk and their potential for collateral damage. So I will stop here, and I will be happy to take any questions that you guys may have at this time.
Thank you so much, Dr. Lee. We do have one question in the chat, which is, what are your thoughts on duration of IV treatment of an uncomplicated UTI for a patient in the hospital for another reason? Often we see longer courses, 5 to 7 days, when used for uncomplicated UTI in hospitalized patients, even when IV therapy such as ceftriaxone is used. I've always thought that 3 days of IV therapy was sufficient in these cases.
So just to backtrack a little bit, sometimes I think it really depends. So sometimes in these patient situations, treating a UTI may not be the only thing. I know at my practice site, we see a lot of complex patients where they think, okay, uncomplicated UTIs may be one of the reasons, but they're also suspecting other reasons, for the patient to potentially have the infection. So I think one would be determining, it kind of falls back into the diagnosis. Are we treating just a straightforward UTI? Because if it's uncomplicated, straightforward UTI in the hospital setting, you probably may not even need an IV antibiotic, right? And then really looking and assessing for the patient's clinical response, if we are treating just strictly just a UTI, then shorter duration would be sufficient if they are responding. But however, if that patient may have other reasons or other issues that the team may be working up, then I think it makes it like a little bit more complicated and requires us to kind of dig in a little further about the patient in order to make a good recommendation.
All right, I do not see any other questions in the chat, and in the interest of time, we can sort of close out today's webinar. I want to thank Dr. Lee again for giving such a great talk today, and thank you for everyone in attendance for your attention and participation. I was told that the information for claiming CE will also be sent out to participants on Monday as well, with the specific information for how to claim the CE. That will be coming from the New York State office, as well as a reminder that CE credit, there will be a survey evaluation that should be filled out within 15 days of the activity, and to remember to make sure that you claim your credit within 60 days to get credit through ACCP. With that, you should be receiving that email within 1 week from the NYSCHP office. And with that, we will close out today's webinar, and thank you all for attending.